Good morning, everyone. Thank you for the introduction. I'm really excited to share a quality improvement project that we did, the Neonatal Embedded Social Support Team, which was rooted in a desire to improve social screening and resource connection in the NICU and nursery at San Francisco General Hospital. So as of 2016, the American Academy of Pediatrics recommends universal ESTO screening for all infants, but there is no standardized approach across the healthcare settings. And so while many institutions recognize the importance of screening, the challenge really lies in how to implement effective workflows and identify social needs and ensure that all families get connected to the resources that they need. So at San Francisco General Hospital, a public county safety net hospital that serves a very diverse and historically underserved population, we wanted to evaluate how ESTO screening was being conducted in the NICU and nursery. Again, at San Francisco General Hospital, the current ESTO screening process for infants occurs in this manner. The first time is upon admission to labor and delivery, and the survey is conducted by L&D nurses there. The second is prior to discharge, where from the NICU and nursery, where the survey is conducted by the pediatrics team, which is composed of residents and medical students. But despite these efforts, we found that healthcare providers face challenges in connecting families to appropriate resources and effectively conducting screenings. We conducted semi-structured interviews with the nurses, physicians, and social workers where we identified 3 key barriers. The first was time constraints, because providers are often overwhelmed with other clinical responsibilities. The second was a lack of standardized workflow, where there was no clear process that dictated who was responsible for follow-up and how resource connections should be made. The last was limited training, because many providers felt that they were unequipped to navigate the next steps after identifying a social need. And combined, these barriers really resulted in missed opportunities to address ESTO needs. So we conducted a root cause analysis, which revealed that the medical team is often overburdened with competing clinical responsibilities, which lead to inconsistent screening practices and poor resource connections in families. Through these interviews, though, we identified existing programs at San Francisco General Hospital. One of them is called the Health Advocates Program that trains volunteers to carry out standardized social and legal needs screenings with families. There's also another program called the Community Health Workers, which work with Homeless Prenatal Program, and they are also trained extensively in ESTO screening. So recognizing that there existed this group of trained ESTO screeners at the General already provided an opportunity for us to try and integrate them within the nursery and NICU workflow. The idea was to create a standardized workflow that embedded the health advocates and the community health workers into the screening process. And so our key objectives were, 1, to optimize the screening rates in the NICU and nursery, and 2, to ensure the families were connected to appropriate resources, which would hopefully reduce the burden of screening on the medical team so that they could focus on what they do best, which is attending to the medical needs of the families. To address these objectives, we launched the Neonatal Embedded Social Support Framework, which the model directly integrates health advocates and community health workers into the screening workflow. And so that meant that there were designated days within the week where health advocates and community health workers were in charge of conducting ESTO screening in the NICU and nursery. So when a family screened positive for an unmet social need, the health advocates and community health workers could provide real-time resource connections. This is in contrast to how it worked previously, where a physician might identify a social need, they would then place an order for social work to come and chat with them or follow up with a phone call at a later time. And a later time could mean the same day or it could mean months later. So this approach we found reduced provider burden, ensuring that the trained personnel could handle the ESTO discussions and enhance resource connection and efficiency. The NEST program launched in February of 2024, and we collected data for 6 months through July of 2024. There were many challenges, which included inconsistent documentation of ESTO screening from providers, which complicated the tracking of screening rates and follow-up. There were also various limitations within the existing electronic health record, which hindered our ability to capture and analyze data uniformly. Securing provider buy-in was also very difficult because integrating screenings into the existing workflow were additional hurdles. And I can expand on this by adding that at the General Hospital in the pediatrics department, there are new resident physicians that cycle through every couple of months and sometimes as short as every couple of weeks. So whereas they might work at different hospitals throughout the same year, they're used to different workflows for screening for ESTO. And so coming to a new hospital, learning a new system, only being there for a couple of weeks and then being replaced by a brand new team who needs to relearn these workflows was very challenging. Taking a closer look at the data that we collected, this first chart shows the percentage of positive responses by department. So in the brown, we can see the percentage of positive responses by the labor and delivery unit, which again, the screening was conducted by nurses. And in the blue, we see the positive screening responses in the NICU, which the screening there again was being done by the health advocates, the community health workers, and the physician team. You can see that the NICU had more than double the positive responses than the rate of L&D. In the second chart, we see the overall positive responses by role. So the first bar there is from the community health workers. The second is the health advocates. Third is the physicians and families of the newborns. And then the last one is the labor and delivery nurses. So unsurprisingly to us, the community health workers found the most positive needs, and they are the most extensively trained in how to screen for social determinants of health, and also the most knowledgeable about resources in the community. These results to us suggested that embedding trained personnel could improve ESTO identification and efficiency of resource connection. Reflecting on our outcomes, we wanted to highlight some of the reasons that we feel we are seeing a disparity in the screening positivity findings in between the two departments. The first being that the stress and the physical demands of labor can really influence a parent's ability to fully engage in ESTO screening at the time of admission to L&D. But also, the families stay for a longer time in the nursery and NICU, which can allow for more interaction with the social screening team, and especially if they're engaging with specialized personnel that are trained to handle ESTO screening and resource connection, we feel that this can lead to a more comprehensive screen in general. Looking forward, we're really hoping to escalate the NEST framework to other departments in the pediatric unit. Right now, it's only currently being done in the NICU and the nursery, but there's also the wards and also labor and delivery, and of course, adult medicine as well. We'd also like to pivot to a more qualitative focus where we want to better understand the patient's perspectives because we want to make sure that our interventions are effective and sensitive to their needs. That's all I have. Thank you for your time. I just want to acknowledge all of the people that put some time and effort into this project.